By the end of this lesson, contraception, what I want you to have is your options, seen on a spectrum from highly effective to not very effective, and understanding the risks and the benefits of each method of contraception. Recognizing that when you choose a method of contraception, or whether you choose it all, it will likely be individualized for your patient and her belief systems, not yours. I want you to see them as things that work really well, things that they work pretty good, and things that don't work so well at all. And this is going to be speaking directly towards contraception, also from the perspective of population level contraception. That is, it's not the one time you use it that makes it good. It's using it over and over and over again over many people and attempting to prevent conception. The most effective, the highest on the effective list, is going to be long-acting reversible contraception. LARC has been defined as the thing to do. Anyone who can get pregnant and does not want to should be offered LARC. Girls, women, any reproductive age female whose goal it is to not get pregnant should use long-acting, reversible contraception. LARC comes in two forms, the non-IUD form and the IUD form. IUD stands for implantable uterine device. The idea here is that these things that are the most effective are implanted somewhere. The non-intrauterine devices, the planons, explanon and implanon, are injected under the skin. Women like this because they don't have to go through a gynecologic exam to put it in or take it out. The downside, though, is that it's only good for about 3 years. In the form of intrauterine devices, you have two major forms, hormonal and copper. Copper has the benefit of being the longest acting. That is, one device is good for 10 years, and there are no hormones. But copper IUDs may increase bleeding. And often women get on contraception to reduce or to control menses. So the copper offers the benefit of having no hormones and lasting longer, but it can increase bleeding. Whereas the hormonal ones, they last 5 years only, and they do have hormones. They have estrogen and progesterone, so technically will increase the DVT risk, but often they will either decrease or stop bleeding altogether. You may have some spotting in the beginning, but then as your body adjusts, menses may simply cease, which is very convenient for the woman who has them. But also effective on the high list, but not as effective as LARC, is non-reversible forms, that is surgical intervention. The masculine form is vasectomy. The feminine form is bilateral tubal ligation. Technically, a total abdominal hysterectomy is the best way to prevent conception, but it is not recommended as a form of contraception. But if she has her uterus out for something else, then she obviously cannot conceive. The BTL offers the benefit of being able to be done during a C-section, so often surgical sterility is achieved during the C-section. It is irreversible, but not always 100% effective, because all you do is tie down the tubes, you create a stenosis. So if she ovulates and sperm manages to get through, if it fertilizes the embryo, there's a very high risk that the embryo won't get through, and so you'll end up with ectopic. But just because someone has had a BTL does not mean they can't be pregnant, but it is very effective, but not as effective on the scale of LARC. And you'll notice, though, that the invasiveness tends to correlate with the effectiveness. This is true across this lesson, except in the sense of surgical intervention being better than implantation. As you go down the list, you'll see that they become less invasive. The more effective, the more invasive. The more effective, the less control the patient has around the intervention. As we move into moderate, we're going to be talking about some form of ingestion. There are 5 kinds. There are injections, patches, rings. I'm going to refer to OCPs, the combined estrogen and progesterone pills, as pills or OCPs, because we also have the mini pill, which is going to be progesterone only. They're listed in descending order of effectiveness and also descending order of duration. The injections, like Depo-Provera, have the benefit of lasting about 3 months. They're useful in women who do not desire long-term sterilization, but do want to not have to worry about compliance. Either they're non-compliant or they lack the mental capacity to understand the treatment. Injections once every 3 months is an effective way of keeping them from conceiving. Patches, such as Ortho-Evra, can be changed every 1 month. Still convenient. And patches can fall off, but they don't fall off as much as rings fall out. Instead, the thing I want you to learn about Ortho-Evra and other patches is that they have the highest risk of DVT-PE. I do want to pause for a moment and discuss this risk. People talk about contraception and DVTs, and now it's contraception and not just OCPs. We used to say OCPs cause clots. Now it's any form of estrogen. So what you're looking for is 3 things that increase her risk substantially. Any 2 on their own don't cut it. It's going to be contraception in the form of estrogen, along with smoking and being over the age of 35. If you've got 3 of these, you have an increased risk of DVT, so the goal would be change 1. You can't change her age, but you can get her to stop smoking or switch her off an estrogen-containing compound, or she simply can accept the increased risk of DVT. The patches have the highest amount of risk of DVT-PE, and that's the thing I want you to take away. Rings, like NuvaRing, are also combined estrogen and progesterone. They also are replaced every month. But the problem is that they are vaginally inserted. And therefore, if they fall out, she may not know. And also, there have been complaints of during sexual intercourse, the man being able to feel the ring, and it interrupts intercourse and foreplay. So the ring and the patches are about as effective as each other. They about last as long, but they have their own failure modes. Patches cause increased DVT-PEs and can fall off, whereas the rings are vaginally inserted and can fall out. OCPs, combined estrogen and progesterone pills, used to be always the right answer. It is no longer the case that for contraception, OCPs are the best choice. The problem with OCPs is that they require daily compliance. And while there is some variation between the different pills about how long you can miss, 1 day off, she bleeds or can get pregnant. So OCPs are not the right answer anymore for contraception, because if you're going to expose her to the risk of estrogen and progesterone, the cost of daily compliance has been replaced by LARC. So if the goal is contraception, use LARC, because you can take out LARC even before the expiration date of the device, and she can resume fertility. But OCPs are still the right answer for pathologic states. Things like dysfunctional uterine bleeding, chorio or gestational trophoblastic disease, or molar pregnancies. Conditions where long-term sterility are not desired. You're either using it as a diagnostic step or you're treating something else using OCPs. They are still the right answer. You can use LARC, but it's in a setting where a woman does not necessarily desire long-term contraception that you'd use these to treat her temporary condition. The mini pill has the benefit of being progesterone only, and therefore significantly reduces her DVT risk. The problem, it requires daily compliance down to the hour. So that if she misses only a little bit, that's a major failure mode. And since she has to take it daily, it only takes 1 day to trip her up. And that's the thing about the low effectiveness category. The two big ones here are going to be condoms and diaphragms. When used correctly, the one time you put it on, it works very well. The problem is you have to remember to do it every time you have sex, and you have to do it right. So forgetting, not having it break, having it not put on correctly, are failure modes that decrease the effectiveness on a whole. Remember, we're talking population level, not the one time you use it. But these are barrier methods, and barrier methods provide STI protection. And so they're still recommended to be used in addition to a form of long-acting reversible contraception because you prevent STIs. Every other method we've discussed so far does nothing to STIs. And that's actually important. It does nothing to STIs. Providing a woman with contraception does not increase risky behavior, does not increase the risk of sexually transmitted infections. But it also, all these forms so far, don't protect her from STIs either. Barrier methods are the only way to do that. The condom is the masculine form, and the diaphragm is the female form. Condoms are actually very effective if you use them right. The problem is that the responsibility of the man. And he has to have one. She, of course, can have one too. He has to agree to put it on. You do need to interrupt foreplay in order to put it on, but that break is very temporary. The problem is that if you do it wrong, or you don't use it, or you don't have it, it doesn't work. But the benefit is that even though you do have to pause, it's used at the time of intercourse, and the pause is very short. The diaphragm is better since it is female-controlled. She doesn't have to ask him to do anything. But the problem is that it needs to be inserted ahead of time. Or there must be a prolonged delay in foreplay to go put it in. There's some other add-ons, things like the female condom, and then below this, non-barrier methods like spermicide, sponges, and caps. These things were very popular a long time ago, and when used in conjunction with barrier methods, can improve the efficacy. But these provide no STI protection and aren't all that effective at preventing pregnancy because there's no barrier. So if you're going to use spermicide, sponges, and caps, use them in addition to condom and diaphragm. And lastly, there are the things that do not work at all. The first is family planning. It's called family planning, not because you're planning to not have a baby, but because family planning is used to achieve pregnancy. As you'll see in the GYN lecture, infertility, family planning, where you try to time ovulation based on basal body temp or simply counting out the days, is an effective way of getting pregnant, not avoiding it. Probably the worst way is withdrawal. That is using no barrier mechanisms and simply pulling out right before the moment of climax. One, because this is also male-controlled, and during the act of sexual intercourse, he has to remember to actually do it, and that's most likely to not happen. And there's also pre-ejaculate. That even if performed correctly, the pre-ejaculate contains semen and can get her pregnant. And last on the things that don't work are abstinence. Because you actually have to do it. And that one person who abstains from sex entirely will not get pregnant. But on a population level, that doesn't work. So let's say she's using a method, she has sex. Doesn't work, she forgot her pill, whatever. She doesn't want to get pregnant, but she just had sex. For whatever reason it might be, you have the morning after pill. In the morning after pill, levonorgestrel. If used within 72 hours of intercourse, you will prevent the pregnancy. This is important to note that it is not the abortifactant. It will not harm a current pregnancy. It is not abortifacient. This is its own category and used when she has been exposed to sexual intercourse and wasn't intending it, or has one of these mechanisms fail. So I want you to see very invasive surgical insertion, best way, long term. She doesn't have to think about it and doesn't get pregnant. The ingestibles are going to have a lot of variation in the way that she does it. These are less effective in the way of contraception, but are immediately reversible if you stop taking them. And then the things that don't work are the things you have to do every time. You have to have an item or an object, or the worst of all is just thinking about it. So the more invasive, the more procedural it is, the better it works. And remember, the only way to protect against sexually transmitted infections is to have a barrier method or simply abstain. That is contraception.